Good morning, Elena.
Good morning, Dr. Gendel. How are you?
Very sweet. Looks very comfy.
Yeah, he's just waking up.
Headed in different directions. Wow.
Yes, that's
Winter
for
coat
sure.
and no jacket. Okay, it looks like a fair number of us have signed on. So we will start. Good morning and welcome everyone to the December 2023 Journal Club, the last one of the calendar year. To avoid the land acknowledgement becoming a performative act, we have offered a variety of land acknowledgements in this venue, including donations to First Nations groups, links to other charities and initiatives, as well as recognition of Treaty Week at the beginning of November. Today, we recognize that many Indigenous nations have longstanding relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. To raise awareness of our relationship, please consider details of the Toronto Purchase. The 1787 purchase was conducted on September the 23rd. The British Crown and the Mississaugas of the New Credit met to arrange for the sale of lands along Lake Ontario. In the case of the Toronto area, the Mississaugas of the New Credit exchanged 250,000 acres of land in what became York County, most of current Toronto bounded by Lake Ontario to the south, Highway 427 to the west, Highway 404 to the east, and Bloomington Road to the north. And the exchange was for some money, 2,000 gun flints, 24 brass kettles, 120 mirrors, 24 laced hats, and 96 gallons of rum. At the time, the Mississaugas believed that the agreement was not a purchase extinguishing their rights to the land, but a rental of the lands for British use in exchange for gifts and presents in perpetuity. From 1986 to 2010, the Mississaugas opened a land claim settlement process with the Government of Canada to rectify its grievance over the Toronto Purchase. In 2010, Canada agreed to pay $145 million for the lands. The money was distributed to the Ban government. We have two great presentations of cluster randomized controlled trials from experienced Journal Club presenters this morning. To start, Dr. Victoria Chuen, PGY5 Geriatric Medicine resident with an interest in medical education, will present on decolonizing in long-term care. This is also Dr. Chuen's last Journal Club presentation. So we thank her in advance for all of her superb efforts at Journal Club. Victoria, please go ahead.
Thanks, Dr. Gendel. Just going to share my screen. All right, you can see my slides. Yeah, okay. Hi, everyone. So thanks so much. And today I'm going to be presenting on this paper that's titled Decolonization in Nursing Homes to Prevent Infection and Hospitalization. And I also just wanted to thank Dr. Eric Wong for going over some of the numbers with me as I was preparing this presentation. I have no conflicts of interest to disclose. So for today's short journal club, we will first summarize the methodology and key findings of the selected journal article. We'll focus on the critical appraisal of this paper afterwards. So infections are common in nursing homes, and in the United States, they're responsible for 150,000 and up to 380,000 deaths per year on average. And in previous studies, universal decolonization, meaning the treatment of an entire institution or unit, can reduce infection risk in the ICU and the number of MRSA carriers following hospital discharge. The use of chlorhexidine has previously been shown to reduce multi-resistant organisms and blood infections in acute facilities, and the use of iodophor nasal swabs have been shown to be effective at reducing MRSA colonization of both the nose and skin when used together with the chlorhexidine baths. Of note, a universal approach has also been shown to be more effective than screening and then treating individuals who have been carriers of various organisms. So now moving on to our paper, which was published in the New England Journal of Medicine in October 2023. The population evaluated in the study were residents living in nursing homes, specifically within the state of California in the United States. The intervention group underwent a universal decolonization protocol with chlorhexidine and nasal iodophor, whereas the comparator continued with the routine care bathing. The primary outcome was transfer to hospital due to any kind of infection, which was determined by the nursing staff at the time of transfer. And then the secondary outcome was transfer to hospital for any reason. More specifically, their intervention protocol involved treating all consenting residents with nasal iodophor swabs twice daily for 5 consecutive days, followed by twice daily for 5 days on alternating weeks. And then residents in the intervention group also received all baths using chlorhexidine, including at the time of admission, and then with all subsequent baths thereafter. And there was also no formal requirement for a minimum number of baths per week, according to the study protocol. The study was a cluster randomized control trial across 28 nursing homes in California. The researchers excluded any nursing homes that were dedicated to pediatric, dementia, or psychiatric care, or if they were already engaged in some kind of decolonization protocol. The unit of randomization here was the nursing homes themselves, where initially the nursing homes were assigned in pairs to help balance key characteristics between groups. And then within each pair, there was a 50-50 chance of being assigned into the treatment or the control group. The study periods outlined here included a baseline period lasting 18 months for collection of baseline data prior to the intervention period to assess patient characteristics used for randomization, but also to assess the primary and secondary outcomes prior to their intervention at baseline. Then there was what they called like a phase-in period, which lasted 4 months. And during this time, only the intervention period received in-person training sessions, coaching calls. They received toolkits of the intervention protocol, training materials, and staff and resident handouts about the protocol. Finally, there was the intervention period, where in the treatment group, they had the chlorhexidine baths and the nasal iodophor swabs. And then in the control group, they continued on with their routine care bathing. And then this lasted for another 18 months for their data collection. In terms of their statistical analysis, they performed an intention to treat analysis, which was defined or labeled as their as assigned analysis, and then an as treated analysis, discounting the nursing homes that had dropped out. They also performed analyses adjusted for individual age, sex, race, ethnic group, insurance, diabetes, and cancer. And then they assessed differences between groups by performing a linear mixed log binomial regression model. They had nearly 29,000 residents in their study, about 15,000 during the baseline period and just about 14,000 in the intervention period. And they had 4 nursing homes that dropped out following the randomization process. 1, which was in the routine care group, and then 3 in the intervention group. 1 group in the routine care arm and 2 in the intervention arm dropped out due to the administrative turnover and loss of support. And then 1 in the treatment group dropped out due to efforts required during the phase-in period. In terms of adherence within the treatment groups, 95.6% of residents received a chlorhexidine bath at the time of admission, and slightly less at 87.4% continued on with the routine bathing using the chlorhexidine. Conversely, the adherence to the nasal iodophor swabs was much less at 60.3% of individuals receiving swabs at the time of admission, but slightly more at 67.4% receiving routine administration of the nasal swabs afterwards. So here are the baseline characteristics of the residents, which is based on the residents and facilities and the intention to treat analysis. The treatment group had slightly more participants, and we also see that they generally had more white participants. And then to highlight looking at the coexisting conditions, the authors did not collect any information about cognitive impairment or a dementia diagnosis. And we also see that in the routine care group, they had slightly more individuals with diabetes. Now, looking at the baseline characteristics of the nursing home facilities, we can see that in the treatment group at baseline, they would have what they measured at 4.4 baths per week, whereas in the control group, they had 3.2 baths per week. However, in the subtext under the table, they also state that the frequency of bathing in nursing homes across the trial groups and trial periods was 3 times per week on average, even though they stated that they didn't necessarily mandate any change in the bathing frequency. Additionally, there was also slightly higher baseline use of antibiotic treatment administered in the treatment group at 3.4 compared to 2.9 in the control group. Now, in terms of the trial outcomes, because this was a cluster randomized control trial, the authors calculated the risk ratio for each the control and the treatment group, comparing the baseline period to the intervention period, and then subsequently using their model to calculate the differences in their risk ratio. Overall, you can see that in the decolonization group, there is an overall lower risk ratio with the effect of the chlorhexidine and iodophor intervention, with both outcomes being transferred to hospital due to infection and their secondary outcome of transfer to hospital for any reason. And then for the intention to treat analysis, the number needed to treat to prevent 1 hospitalization due to infection was 9.7 residents, and the number needed to treat to prevent 1 hospitalization for any reason was 8.9. And then in the as treated analysis, the numbers needed to treat become smaller. Now, looking at those impressive numbers needed to treat, it's important to kind of reflect and look at the adverse events. So they reported a total of 35 adverse events during the entire study period. And related to the chlorhexidine, there were 34 reports of rash, 26 which resulted in discontinuation. However, 26 instances actually occurred during the initial phase and training period, and 12 were reported by a single nursing home on the first day of implementation, and ultimately determined by a trial investigator to be related to a pre-existing inguinal-candidiasis. Regarding the nasal iodophor, only 1 adverse event was reported, which was a sore throat, and it didn't result in any discontinuation of the product. So now moving on to our critical appraisal and first looking at the internal validity of the study. So first, was the assignment of patients to treatment randomized? So yes, it was, because of the biases and cross-contamination that would have been introduced had the unit of randomization been at the individual resident level. The study implemented a cluster randomized controlled trial approach. And they first assessed the baseline characteristics of the nursing homes to ensure that they were balanced between pairs of nursing homes, and then randomized them accordingly. And generally, this is an acceptable approach in the cluster randomized controlled trials, as it minimizes the risk of potential confounders between groups. And in this case, they did try to balance variables such as their baseline outcome, numbers of baths per week, antibiotic use, and others. Secondly, were the groups similar at the start of the trial? So somewhat. So when we looked at the table 1 earlier, although the authors did try to balance some of the baseline characteristics, there were still some small differences that existed, such as the control group being slightly more racialized, having more individuals with diabetes, overall having less antibiotic use and less baths at baseline, which may have had implications on the infection control. And then aside from the allocation treatment, were the groups treated equally? So somewhat as well. The authors reported no other differences were implemented by the study protocol. However, in addition to the intervention of the chlorhexidine baths in the iodophor nasal swabs, the treatment groups actually also received that intensive training and support during the phase-in period and the intervention period as well. And that, of course, could have had effects on the measured outcomes. And then as well, the nursing homes in the treatment group actually switched their laundry detergent from using chlorine to peroxide bleach to avoid a chemical reaction between chlorine and chlorhexidine, because that is associated with causing irreversible stains. And it's unclear how this might have affected the measured outcomes as well. Were all patients who entered into the trial accounted for, and then were they analyzed in the groups to which they were randomized? So yes, the authors performed an intention to treat analysis, which was their as assigned analysis, and then a separate as treated analysis, which had discounted the nursing homes that withdrew from the study. Were measures objective and were the patients and clinicians kept blind to which treatment they had received. The overall outcome of counting a transfer to hospital is technically an objective measure that can be easily defined. However, actually with their primary outcome, where a transfer due to infection, I would say is a bit more subjectively determined and was actually up to the discretion of the nurse that was capturing the data at the time of the transfer to hospital. And due to the nature of the treatment, of course, the study wasn't able to conceal or blind the intervention group. And this could have influenced their assessment of the infection status of the patient at the time of transfer to hospital, since they relied on the nursing information rather than any medical workup that was actually completed in hospital thereafter. And then they also didn't comment on any blinding of results during the statistical analysis. And now assessing the results, how large was the treatment effect and how precise was the estimate of the treatment effect? So the study evaluated the differences in risk ratios between the control and treatment groups. And for the transfer to hospital due to infection, this was 16.6% with a calculated absolute risk reduction of 10.3% and a number needed to treat of 9.7. For the secondary outcome of transfer to hospital for any reason, there was a difference in risk ratio of 14.6% with an absolute risk reduction of 11.2, a number needed to treat of 8.9. However, it's important to remember that this number needed to treat here is at the individual resident level, whereas the intervention that we're actually talking about is being implemented at the level of the institution, given that it was a universal protocol being applied rather than an individualized or targeted approach on each resident. And so now moving on to the external validity of the study and whether these results will help me in caring for my patients. So there's a number of considerations on whether we can apply the procedures and results to our patient populations here in Canada. The first, I think, is with regards to patient population. The authors didn't collect any baseline data about cognitive impairment, which I feel does have relevance in terms of the implementation and acceptability of the intervention by patients. And they also didn't collect any information on the advanced directives of patients. And these decisions not to transfer to hospital could have impacted the measured outcomes. In terms of the feasibility within a Canadian healthcare system, we have to consider the additional costs of not only changing the products, such as using the chlorhexidine instead of regular soaps, but also the addition of iodophore nasal swabs in the time and personnel required to implement this in an already resource-limited healthcare system. And this study received funding for all of the cleaning products that they had used in the intervention period. And although the study demonstrates a low number needed to treat, this is also an intervention that requires an entire facility to engage in rather than at an individual patient level, which obviously factors in terms of the cost. And in terms of the long-term harms, the study also evaluated the intervention over 18 months, which is fairly long. However, we don't know the implications of potentially even longer harms to patients, such as potential skin reactions, or also the risk of promoting organisms resistant to the treatment interventions. And then finally, the study also does not measure other outcomes that would be important for our patients, such as the impact on their quality of life and the acceptability of the interventions. So in terms of the bottom line, universal combination of chlorhexidine bathing and nasal iodophore swabs in nursing homes does reduce the risk of transfer to hospital due to infection. However, the takeaway from this paper, I think, is limited by the uncertain applicability in a Canadian healthcare system, perhaps the tolerability and feasibility of the study in a real life setting. Here are my references. And thanks so much. Happy to take any questions or comments.
Thank you very much, Victoria, for a beautiful presentation. Made me think of the products I used this morning before, and what a personal decision it is, or how, you know, people choose very carefully what they're going to use as their cleaning products. Anyways, I open it to the audience for questions. And Victoria, perhaps I can ask you just to stop sharing for an easier. Gary, I see your hand up. Go ahead.
Victoria, lovely presentation. you've touched on it, but I'd ask you maybe to speak a bit more to the differences between the intervention and control groups. In the context, you note that there were a variety of small differences, but it did seem that the majority of those small differences possibly biased against the control group, because the nature of the things that were different were possibly things that may also result in increased risk for infection. So can you tell me how significant you think that those small differences between the groups may have been in contributing to the differences found?
Yeah, good question. I think it's hard for me to kind of gauge or to put a number on it, but I think, of course, with a multitude of small differences, there's a potential that that can combine together and contribute to a greater effect that I don't know necessarily whether I have the answer to, but I suspect that it's still a consideration when we're evaluating the results and interpreting them to consider.
Yeah, I mean, I think the reason that it struck me is I believe the control group more racialized, more diabetes,
Yeah.
more use of antibiotics that could increase antibiotic resistance. They just seemed like virtually all the ones that were different would work against the control group. So
Yeah.
it's hard to know combined whether that's important or not.
Thank you, Gary. Shabir has his hand up. Go ahead.
Yeah, Victoria, I echo Gary's comments. It was a great presentation. It was interesting that the number of people admit, or the NNT for people being transferred to hospital for any reason was slightly better than the NNT for being transferred for infection alone. Why do you think that might be?
I'm not too sure, to be honest. I don't know if anyone else has ideas.
Yeah, I'm not absolutely sure either. Whether they're truly different or not is unclear because we don't really have a sense of the uncertainty around them. They may just be 8 versus 9, and it may just all be a wash. You wonder if part of it may be the potential assignment bias because the nurses knew they were the ones assigning the reason for transfer. Maybe I'm not sure. I suspect it's probably just a nothing really, but it is interesting. So I just wanted to see your thoughts. Thanks.
Thanks, Shabir. We have time for one more question. Go ahead, Barb.
Thanks, Victoria, for a great presentation. And I appreciate your comment, Dov, about personal choice for these products. If anyone's ever tried chlorhexidine wash for a pre-op preparation, it's really not a pleasant thing. And the idea of using it continuously would really be off-putting. I'm just wondering, how important do you think it is for the staff to get decolonized? In the acute care setting, there's, transmission between patients based on staff who are carriers. Do you think it's important for the staff in the nursing home to get decolonized as well?
Yeah, that's a really good point. And I'm sure I would suspect that if the protocol included decolonizing the staff as well, probably maybe the effect would be even better. Definitely the protocol didn't mention anything about staff. And additionally, I was curious about what about like hand washing and things like that for the patients, like after they use the washroom and things like that. But they didn't comment on extending the protocol to hand soap being chlorhexidine soaps. I suspect it would improve the outcome, but
thanks.
Yeah.
Thank you. And an extension to the comments with many QI methodologists on the line, I wonder, with the limitations of the RCT and the points that Gary and Shabir made, I wonder if this would lend itself better to QI methodology over time than a cluster RCT. But with that, we're out of time for the short presentation. Please add additional comments to the chat box, and we'll move on to our second presentation, coming to us from Dr. Carolyn Tan, PGY6 in geriatric medicine, and also a concurrent clinical pharmacology subspecialty resident, who will present another cluster RCT on pharmacogenomic testing guiding medication decisions. Carolyn, please go ahead.
Is that showing up okay?
Yes, that's great.
Okay, perfect. Good morning, everyone. Today I'll be discussing the PREPARE study on the use of preemptive pharmacogenomic testing to prevent adverse drug reactions. I have no conflicts of interest. So our objectives for today are to review the current state of pharmacogenomics, to critically appraise the study, to review unique aspects of appraising cluster crossover or CTs, and to reflect on the future of pharmacogenomics. Pharmacogenetics is defined as the study of drug response variation due to an interaction between a drug and a single gene. The term was first coined in 1959, but recognition of inter-individual variability in response to food and drugs has been recognized since 500 BC, when Pythagoras described the occurrence of hemolysis in certain individuals after ingesting faba beans, which we now know is due to mutations in the G6PD gene. With the advancement of gene sequencing, the term pharmacogenomics was introduced in 1997 to describe the interaction between a drug and the entire genome. And today, these two terms are often used interchangeably. Over time, the focus of pharmacogenomics has shifted towards a more proactive approach of trying to predict adverse events before they occur. In addition to predicting adverse events like abacavir hypersensitivity, pharmacogenomics can also be used for predicting drug dose. For example, for thiopurines based on variation in the TPMT gene, and for warfarin based on variation in CYP2C9 and BCORC1. It can also be used to improve drug efficacy and predict activation of prodrugs. For example, clopidogrel, which requires metabolism by CYP2C19 into its active metabolite. People with reduced function alleles who were on clopidogrel after PCI were found to have a 3 times higher rate of stent thrombosis compared to those without reduced function. And lastly, pharmacogenomic results can be used for the development of new drugs like crizotinib for ALK-positive lung cancer and PCSK9 inhibitors for lipid lowering. The benefit of PGX testing is well documented for several single gene-drug pairs, and gene-drug interactions can lead to similar effects as drug-drug interactions, but are often not considered by drug labels and prescribers. With the shift towards more proactive strategies, there has been growing interest in preemptive testing using a PGX panel, since over 90% of people have at least one actionable variant, and almost everyone above the age of 70 is exposed to at least one drug with pharmacogenomic guidance. However, the evidence for a clinical benefit of such preemptive testing strategy is limited. A study published in 2022 looked at the feasibility of pharmacogenetic testing in nursing home residents. 19 of 67 participated, of which 17 completed testing. And they found that 76.5% had at least one major or moderate gene-drug interaction. They concluded that recruiting participants, collecting samples, performing testing, and identifying gene-drug interactions was feasible. However, it remains unclear if these interactions would be associated with observable clinical harm and how these test results should be incorporated into clinical care. Also in 2022, a systematic review was published in Nature's Pharmacogenomics Journal on the use of pharmacogenetic testing to improve outcomes in patients with multimorbidity or polypharmacy. They found 15 studies of variable design and quality, including only one randomized study that reported on clinical outcomes published in 2017. They found that pharmacists' recommendations based on the results of a 6-gene panel led to a reduction in readmissions and emerge visits compared to standard pharmacist-guided recommendations. However, this study was at high risk of bias, and given the lack of high-quality studies, the authors stated that they believe that PGX-guided therapy holds promise, but more studies are needed to establish the impact of PGX screening on patient outcomes. So this is where the PREPARE study comes in. This was an open-label, multi-centered, controlled, cluster-randomized, crossover implementation study published in The Lancet in 2023. Their objective was to investigate the effect of a genotype-guided prescribing strategy using a preemptive 12-gene pharmacogenetic panel across different healthcare settings. In addition to being open-label, multi-center, crossover, and cluster randomized, they used a cross-sectional design such that each cluster period consisted of different participants. instead of a cohort design where it's the same participants continuing through and eventually crossing over to the other group. The study took place in 7 European countries: Austria, Greece, Italy, the Netherlands, Slovenia, Spain, and the UK. And each country was considered a cluster and included a mix of hospitals, community health centers, and community pharmacies. They included participants who were 18 or older and were receiving a first prescription for a drug that had an actionable DPWG recommendation. This first drug was referred to as the index drug. They excluded those who had prior genetic testing relevant to the index drug and those for whom treatment was planned for less than 7 consecutive days. They also excluded those with severe renal or liver impairment. The intervention involved completion of a 12-gene pharmacogenetic testing panel and delivery of the results and corresponding recommendations to the prescribing physician or dispensing pharmacist within 7 days after index drug prescription. The recommendations could then be implemented at the discretion of the physician or pharmacist. The 12-gene panel was selected based on predefined criteria, including the presence of an actionable DPWG recommendation, established effect on protein functionality, and a minor allele frequency, which is the frequency at which the second most common allele occurs in a given population of at least 1%. They ended up with a 12-gene panel with 50 germline variants affecting 42 drugs. I've listed the 12 genes here, along with a single example of a drug for which an actionable recommendation exists. And some of you may be wondering, where is CYP3A4? The variability in CYP3A4 activity is high, and it's contributed to by various factors like drug-drug interactions, foods like grapefruit juice, age, gender, and inflammatory processes. There is likely a genetic component, but all of the currently known CYP3A4 polymorphisms are rare, which is why it was excluded from this panel. And given the real-world design, changes to the panel were allowed during the study based on new evidence. The 42 eligible drugs came from a variety of classes as shown here. I will note that abacavir was excluded since HLA-B57 is already routinely tested, and PPIs were excluded since the recommendations focus on increasing efficacy in CYP2C19 ultra-rapid metabolizers instead of reducing ADRs. And to help ensure that the patient and drug populations were balanced between groups, the inclusion of any given index drug was capped at 10% in each arm. Participants in the intervention group received the results on a safety code card that listed the actionable variants and the drugs affected. It also included a QR code which led to a website. On the website, there was a list of drugs with actionable recommendations for that patient. And when you click on a drug, it would provide the dosing recommendation along with the rationale for the change and potential risks of standard dosing. Clusters were block randomized with a block size of 2 to start with either genotype-guided drug prescribing or standard care. After 19 months, the clusters crossed over to the other group and new participants were recruited at each site. Due to the nature of the intervention, participants, physicians, pharmacists, and assessors were all not blinded. The primary outcome was the incidence of causal and clinically relevant adverse drug reactions within the 12-week follow-up period. Causal was defined as either definite, probable, or possible by the Liverpool Causality Assessment Tool. Clinically relevant was defined as grade 2 to 5 severity on the CTCAE. All ADRs were assessed by a trained physician or pharmacist from the study team for causality and clinical relevance. The secondary outcome reported in this paper was physician or pharmacist adherent to the DPWG recommendations. There were also a variety of other secondary outcomes specified in their protocol, like frequency of drug discontinuation due to ADRs or lack of efficacy, number of dose adjustments, and cost that will be reported in future papers. Data was collected in the following ways. So first, research nurses contacted participants at regular intervals using a script to ask about ADRs. Second, participants could self-report via an online survey at 2 and 8 weeks. Third, participants were to notify the study team every time they receive a prescription for an eligible drug, which would trigger an identical 12-week follow-up. And fourth, researchers asked physicians and pharmacists about adherence to the recommendations and, if applicable, reasons for not adhering. Data collected by these three methods were used only as secondary outcomes. Local teams were educated during a site initiation visit, and online educational materials were made available. These included educational videos such as this one. It shows an older adult sustaining a very dramatic fall and how the adjustment of her beta blocker based on her CYP2D6 poor metabolizer status helps her feel a lot better. They also had brochures and an interactive serious game. Baseline characteristics were compared between treatment groups using chi-squared and Wilcoxon tests. The primary outcome was analyzed using mixed logistic regression. They included country as a factor, along with random center level and center by country interactions. Covariates included age, number of drug allergies, number of co-medications, and the global health score. All analyses were intention to treat and irrespective of adherence to the DPWG recommendations. For the primary outcome, they used a gatekeeping analysis to help reduce the risk of type 1 error. In the first analysis, they looked at the primary outcome only in those with an actionable drug-gene interaction. The intention was to quantify the absolute impact of PGX-based prescribing without its effect being diluted by the frequency of actionable drug-gene interactions. In the second analysis, they looked at the primary outcome in all participants to help quantify the impact of population-wide implementation. With the gatekeeping, the second analysis would only be done if the first analysis yielded a statistically significant result. Between March 2017 and June 2020, 41,696 were assessed for eligibility and 6,944 were enrolled, with 3,300 in the study group and about 3,600 in the control group. About 25% of participants in each group had an actionable variant for their index drug. Due to withdrawing consent and loss to follow-up, data was missing for 12.5% of those in the intervention group and 9.2% of those in the control group. Median age was 58, and 51% of participants were female. Self-reported ethnicity was European, Mediterranean, or Middle Eastern for 98% of participants, and the mean number of drug allergies per person was 0.38. It's my understanding that we shouldn't be using statistical tests for baseline characteristics in randomized trials. However, they reported that there was a statistically significant difference in the mean number of co-medications at 6.85 per person in the intervention group compared to 8.83 in the control group. They also reported a small but statistically significant difference in global health score, which assesses the physical, mental, and social health of participants. The lowest possible score is 0.328, and the highest is 0.877. Even after searching online, it remains unclear to me how this translates into phenotype, but I think it's unlikely that the 0.01 higher score in the control group represents any clinically meaningful difference. And I do think that reporting this as statistically significant has the potential to be misleading. 93.5% had at least one actionable variant, and the most common index drugs were atorvastatin, clopidogrel, and tacrolimus. In the first gatekeeping analysis, which included only those who had an actionable variant, the development of a causal clinically relevant ADR occurred in 21% of the intervention group and 28% of the control group. The second gatekeeping analysis included all participants. I believe that the caption for this figure is actually incorrect and only applies to the left side of the figure, since the right side actually includes all participants. When all participants were included, ADRs occurred in 21% of the intervention group and 29% of the control group. Both yielded an odds ratio of 0.7, favoring the intervention. This table illustrates the impact of predefined covariates on the primary outcome. The left side includes all participants, while the right includes only those with an actionable variant. There was a decreased risk of ADRs with better global health score and higher age, whereas there was an increased risk of ADRs with a higher reported number of drug allergies and co-medications. Intuitively, these make sense, except for the decreased risk of ADR with higher age. And I wonder if this reflects a lower propensity to report or attribution of potential ADRs to non-drug causes like comorbidities. In the study group, 13.7% of all participants received a second prescription with actionable recommendations. When ADRs from subsequent prescriptions were included, the effect of the intervention increased slightly with an odds ratio of 0.69. When the primary analysis was repeated with all participants and all reported ADRs without filtering for severity and causality, the effect of the intervention increased with an odds ratio of 0.55. This suggests that the intervention also reduced reporting of symptoms that were unlikely related to the drug, which increases my suspicion of participant knowledge of allocation influencing their reporting of ADRs. Physician and pharmacist adherence to the DPWG recommendations was 70%, and I couldn't find any information on how adherence differed between physicians and pharmacists. The authors concluded that the genotype-guided prescribing using a 12-gene pharmacogenetic panel significantly reduced the incidence of clinically relevant ADRs. They believe that their results provide evidence to support large-scale implementation of panel-based pharmacogenetics testing. But do we agree with their conclusions? We'll see after we appraise the article. So we will first look at whether we think the results of the trial are valid, including additional domains for cluster randomized and crossover trials. Our first domain is bias arising from the randomization process. Was the allocation sequence random? Yes. And was the allocation sequence concealed? This was actually unclear. We don't have enough information. But I do note that whenever blocking is used, it may be possible to predict the last assignments within each block, especially if the block sizes are small and equal, such as in this study. Did the baseline differences between groups at the start of the first period suggest a problem with the randomization process? This was actually also unclear as they provided minimal country-level baseline data. So overall, I had some concerns about about bias in this domain. The next domain is bias arising from identification or recruitment of participants, which can occur in cluster randomized trials where the intervention assignments are known prior to individual participant recruitment. Were all the individual participants identified and recruited before randomization of clusters? No, this was done after randomization, as we can see from this figure. Is it likely that selection of individual participants was affected by knowledge of the intervention assigned to the cluster? Probably yes. Physicians and pharmacists who were not blinded to the intervention assignments assessed them for eligibility, resulting in the potential for identification or recruitment bias. Were there baseline imbalances that suggested differential identification or recruitment of participants between groups? Yes, those in the study group were on 2 fewer co-medications compared to those in the control group. So overall, for domain 1B, I gave the study high risk. The next domain is domain S, risk of bias arising from period and carryover effects in crossover trials. Period effects are systematic differences between responses in different time periods that are not due to the intervention. For example, if the underlying condition changes systematically, or if there are background factors that change over time. If the number of participants in each sequence is equal or nearly equal, then any period effects should cancel out. In this study, the recruitment ratio was approximately 2 to 1.5 for the first period, which then reversed for the second period. This is one of the limitations of using block randomization for cluster RCTs. It can help improve the balance in numbers of clusters, but does not necessarily address the number of participants within clusters. Were period effects accounted for in the analysis? No, I didn't see any evidence that this was done. Was there sufficient time for any carryover effects to have disappeared before outcome assessment in the second period? Yes, they recruited a new set of participants for the second period, so there would be no carryover effects. There is the possibility, however, of carryover effects on prescribing behaviors for physicians and pharmacists who received the intervention during the first period and then were part of the control group during the second period. So overall, I had some concerns for this domain. Domain 2 is bias due to deviation from the intended intervention. Were participants aware that they were in a trial? Yes. And were they aware of their assigned intervention during the trial? Also yes, as this was an open label trial. Were people delivering the intervention aware of their assigned intervention? Yes. Due to the nature of the intervention, both physicians and pharmacists were not blinded. Therefore, it is possible that this knowledge influenced their prescribing behavior. Were important co-interventions balanced across groups? Somewhat. The control group received mock safety cards, but the intervention group also received education through an in-person visit and online materials to prepare them for PGX testing, which may have influenced prescribing practices independent of the PGX panel. Was an appropriate analysis used to estimate the effect of assignment to the intervention? Yes, all were analyzed according to their assigned group and regardless of prescriber adherence to the DPWG recommendations. So overall, I also gave them some concerns for this domain. Domain 3 is bias due to missing data. Were data available for all clusters that recruited participants? Yes. Were data available for all or nearly all participants within clusters? No. Data was unavailable for 10.8% of participants, with more withdrawing consent and loss to follow-up in the intervention group. Is there evidence that the result was not biased by missing data? No, we don't have that. There was no data provided describing participants who were missing, and there was no analysis performed to assess the impact of missing values. Is it likely that missingness in the outcome depended on its true value? I said probably yes, because there were more participants in the intervention group who were lost to follow-up compared to the control group. So overall, I gave them a high risk for this domain. Domain 4 is bias in measurements of the outcome. Was the method of measuring the outcome inappropriate? Yes, there were concerns about lack of blinding, which we'll talk about in a moment. And there was also measurement of adherence concerns in that the research team actually interviewed physicians and pharmacists to ask if they were adhering, and if not, why not? Could measurement or ascertainment of the outcome have differed between interventions within each sequence? Yes. ADRs were identified by unblinded research nurses who interviewed participants who were also not blinded. Furthermore, severity and causality were assessed by a physician or pharmacist from the study team who were also not blinded. They attempted to account for this by having a third party blindly assess a random 10% sample of ADRs. In the main text, they say that there were no significant differences between the two sets of assessments. However, in the appendix, the weighted kappa for causality was 0.31, which is considered poor agreement and raises concern for ascertainment bias. I also note that they made a typo in their appendix and they listed the weighted kappa as 0.16, which is instead parts of the confidence interval. So overall, I said high risk for this domain. Lastly, domain 5 is bias in the selection of the reported result. Were the data analyzed in accordance with a pre-specified analysis plan that was finalized before unblinded outcome data were available for analysis? Yes, the protocol was published in 2017 prior to the start of the trial, so I deem this to be low risk. Overall, looking across our 7 domains, I do have concerns about the validity of the results, primarily stemming from the lack of blinding. Moving on to our next section of the appraisal, how large was the treatment effect? Among participants with an actionable gene-drug interaction, those in the intervention group had a 30% lower risk of ADRs compared to the control group. However, this same risk reduction was found even in those without an actionable gene-drug interaction. So this raises concerns about whether the observed benefit could be secondary to factors associated with the intervention that were independent of the PGX recommendations. For example, more careful prescribing, increased care, or bias secondary to the lack of blinding. How precise was the estimate of the treatment effect? The 95% confidence interval was fairly narrow at 0.54 to 0.91, indicating that the estimate is quite precise. However, this does not necessarily reflect accuracy. Lastly, will the results help me in caring for my patients? Participants in this trial were much younger than our patients, and nearly all were European, Mediterranean, or Middle Eastern. We don't have any information on living situation, frailty, or comorbidities. I think that their intervention would be challenging for us to implement given the limited access to PGX testing and the current lack of expertise on how to utilize the results. The voluntary participation in this trial also likely impacts the generalizability of the results to clinical settings with less interest in PGX testing. So my answer to this question is no, probably not right now. But I do think that this study has a variety of strengths and the potential to impact our clinical practice in perhaps less concrete ways. This study was the first of its kind, using a multi-center controlled cluster randomized crossover design to prospectively evaluate the impact of a PGX panel on clinically relevant adverse drug reactions. It was large and pragmatic and included multiple countries, along with a broad range of drugs and healthcare settings. The authors demonstrated the feasibility of large-scale implementation of PGX panel testing. And I think that this study raises important awareness of the potential impact of drug-gene interactions on prescribing decisions. In terms of cautions, as mentioned during our appraisal, the lack of blinding may have led to various forms of bias. For example, for those in the intervention group, prescribers may practice more cautious prescribing, and participants may be less likely to self-report ADRs if they believe that the treatment has been tailored to their genetic makeup. Knowledge of group allocation by assessors may lead to bias in interviews and also in adjudication of causality and severity of ADRs. A surprising finding is that even those without an actionable PGX recommendation had a similar reduction in the ADR rate. And the effect of the intervention increased when all ADRs were included, regardless of causality and severity. Both of these findings increase my suspicion that bias resulting from a lack of blinding influenced the results. Even without blinding, I think that their conclusions could have been strengthened had they been able to demonstrate a relationship between implementing the PGX-based recommendation and a decrease in ADRs specific to that drug. Prescriber adherence may have been increased by the involvement of researchers. The control group had a higher number of co-medications. There was a lack of racial diversity, and we had no information on comorbidities, nor how the effect of the intervention differed based on healthcare setting. There was also a greater than 10% missing data with higher loss to follow-up in the intervention group. We should also keep in mind that while they labeled this as a preemptive strategy, it wasn't fully preemptive, as the PGX results were not available at the time of prescribing the index drug. A truly preemptive study would likely require at least a 10 to 20 times larger sample, since many would not start an index drug within the study timeframe. While there were various ways that the effect of the intervention could have been overestimated, there were also factors that could have underestimated its effect, including a carryover effect for prescribers who started in the intervention group, then switched to the control group, and the delay in receiving recommendations for the index drug. The delay means that ADRs that occurred prior to implementing the recommendations in the intervention group would have been included. And if a participant is already tolerating therapy, prescribers may be less likely to implement recommendations after receiving them. And lastly, I will just note that most of the secondary outcomes were not reported in this paper, such as measures of drug efficacy and their cost-effectiveness analysis. So in summary, with this study, investigators were able to implement genotype-guided prescribing using a 12-gene pharmacogenetic panel on a large scale with what appeared to be fairly good uptake by physicians and pharmacists. The results initially appeared promising, but based on limitations, we cannot yet conclude that PGX panel testing reduces clinically relevant adverse drug reactions. The authors highlight that actionable PGX variants are ubiquitous, and the results of PGX testing are lifelong and can therefore be incorporated into future prescribing decisions. I think this is an important takeaway from this study, and it does suggest that the potential population impact is high and that this will continue to be a growing area of clinical interest. I wanted to end off by sharing some of my own reflections on this topic, along with some resources. In the future, I do think that PGX will routinely be incorporated into prescribing decisions, like how we consider comorbidities, co-medications, and renal and liver function. I think that when this time comes, some rate-limiting factors to successful implementation may include the development of tools to incorporate the PGX results into daily prescribing decisions, ideally in combination with other factors like co-medications and renal and liver function. Improving the diversity of genomics data so that expected benefits of PGX testing do not exacerbate racial inequalities, provision of adequate patient counseling around the rationale for testing and implication of results, the initial increase in outpatient visits related to sharing PGX results and implementing recommendations in an already strained system, harmonization of drug labeling across regulatory agencies, and the funding and reimbursement of these PGX tests. A very helpful resource for prescribing recommendations based on PGX results is PharmGKB. From the main page, you go to clinical guideline annotations, then you search for the drug in question, and you'll see the recommendations from different organizations, including DPWG, which was used in this study. You can view recommendations based on phenotype, and these may include no change, dose adjustments, or the recommendation to use an alternate agent. There's also the CPIC website where you can view guidelines for different gene-drug pairs. And it's also helpful for getting a quick overview of the FDA recommendations. So this is my last journal club, and somewhere along the line, I got into the habits of closing with a pun or a rhyme, so I'm going to end with this. What do we think of PREPARE? A study like this is certainly rare, an important topic of which to be aware. They even had a control group to compare. But with the limitations, I must be fair. The results don't get me jumping from my chair. With more prospective studies, it should pair, then maybe believe the results I will dare. For now, optimism, I will continue to share that one day PGX will revolutionize healthcare and reduce adverse drug reactions everywhere. Thank you for listening.
Wow, Carolyn, I have to say that was done with great flair. Tremendous. That was such a beautiful and wonderful presentation, a tour de force for your last Journal Club presentation. I will open it up to questions. I appreciate the efficiency too. We have a few minutes for questions. Guillaume, go ahead.
Thanks, Carolyn. Great presentation, particularly a critical appraisal, and very timely with the highly publicized death, unfortunately, of Dr. Anil Kapoor in late November due to adverse drug reaction to 5-FU. And I think part of the media attention was on the fact that this was a reaction where there is PGX testing available, but typically offered to, at least the way it was painted, predominantly white patients, because that is the population where it's most prevalent, that type of genetic mutation. Dr. Alba, feel free to chime in. My question is, with studies like this and ClinPharm studies in general on PGX panels, is there an effort to target specific racial populations or to ensure that there's adequate representation of different racial populations? And you'd mentioned the lack of this, by looking at the specific incidence in a specific racial group and then trying to bolster that certain group compared to others, or if you're looking at one very specific mutation, targeting a specific racial group. Is there anything like that within this study or generally for ClinPharm?
Great point, Guy. And actually, there are some places in Canada that do offer DPYD testing for 5-FU. Like I believe in London, it's actually routinely done, and they're trying to make that more routinely done everywhere across the board. But unfortunately, that hasn't happened yet. To answer your question, so in a lot of the studies of single gene drug pairs, there are some efforts to concentrate more on specific populations. In this study, they did try to cast a broader net, given they're doing an entire panel of genes. However, given geographically where the study took place, they unfortunately didn't have a lot of racial diversity, but I think is a shortcoming of this study and something that we need to keep in mind for future PGX studies.
Thank you. Shabir, go ahead.
Thanks, Caroline. Very, very beautifully done. Very sophisticated critical appraisal. I have many questions, but I'll just ask one. You pointed out the fact that the results of the testing was available, but may not have been given in a timely fashion, particularly since some of the results may have been given out within 7 days of a drug being prescribed. So going back to that, do the authors provide any data on whether or not, how often the drug reactions occurred, like early versus late, or do you have a sense of other ways they could adjust for that in their analyses?
Yes, so the timing from when the drug was prescribed to when people received the results, prescribers, varied anywhere from 1 to 7 days. And the median, actually, there was quite a range across the different countries included as well. They did not, unfortunately, specify how many reactions occurred within the first 7 days. I do note that in their protocol, they plan to do a sensitivity analysis and exclude the ones within the first 7 days in the intervention group, but they didn't actually report the results in the main paper. So I'm not sure what the reason for that is.
That's too bad, but you're absolutely right. That would probably be the most logical way to begin to sort of help us understand that. Thanks.
Thank you very much. We have, it's 9 o'clock, but if we'll give a few more moments for one more question or comment. Shabir, is that your old head?
No, it's a new hand. If
It's a new
nobody
hand.
else has a question, I have another one. Carolyn, can you tell us about the Liverpool tool? Because that's not one that I'm familiar with compared to Naranjo and some of the other scales that we commonly use in North America. What's the performance characteristics of the tool?
Yes, so the Liverpool tool, I do have it included in my in the extra slides in the slide deck. Compared to Naranjo, which is also used, the Liverpool tool is more sensitive but less specific. I believe that the sensitivity was quoted at about 97%, but specificity can be as low as 2%.
Oh,
I know. And they included anywhere from possible, probable, or definite in this study. So I think that is also an important drawback. They didn't say this explicitly, but I think that why they chose this over Naranjo is that they don't have any information on re-challenge with placebo and objective evidence like lab tests, which are used in Naranjo, so they wouldn't have been able to use those criteria. That may be why they chose this over something that was less sensitive but more specific.
thanks.
Okay, thank you very much. I'd like to thank Carolyn and Victoria again for two fabulous presentations. We're going to miss your presentations moving forward next year, but you're always welcome back. By way of announcement, please do complete your evaluations that appeared in your inbox 15 minutes ago. And I wish everyone a meaningful and rejuvenating holiday season. We'll see you again in 2024. Thank you.